Hello and welcome back. I'm Rahul Gosain here with my brother and co-host Rohit Gosain on the Oncology Brothers podcast. As a general hematologist and oncologist, a good portion of our practice ends up being benign hematology. And one of the most frequent outpatient consults we get ends up being venous thromboembolism or VTE. In today's episode of Challenging Cases, we're tackling real-life VTE scenarios, and we'll get a chance to talk through provoked and unprovoked events, treatment durations, and cancer-associated cases. To help us walk through this, we're excited to welcome Dr. Jennifer Vaughn and Dr. Nicolas Gallastegui from the Ohio State University, focusing in hematology. Jennifer, Nicolas, thanks for joining us.
Jen and Nick, welcome. From the treatment option standpoint for DVT or PE, we have low molecular weight heparin, warfarin, DOACs, and which one to pick depends on multiple factors. As Rahul stated, we see quite a bit of this. And this is not just us, it's general medicine, GI, neurology, vascular. As a result, it is very important for all of us to have a better understanding around this. Let's start off with our first case here. We have a 34-year-old who presented to the hospital with lower extremity swelling and shortness of breath. The workup was consistent with lower extremity DVT and a PE. Jen, if there are no obvious provoked scenarios of travel history, and in females, no OCPs, surgery, sedentary lifestyle, malignancy type of systemic signs, what's your usual workup, particularly from hypercoagulable standpoint?
Well, sometimes that can be controversial and differ among different practitioners. Probably one of the reasons we're having this conversation. I will say that with a younger, fit gentleman with no obvious risk factors, I will automatically walk into the room thinking that this gentleman is going to be high risk for a recurrence of a VTE in the future. There are many factors that might lead me to consider doing a hypercoag workup. A lot of times that can be patient preference. Also, whether or not he has any children, especially daughters, whose care might be affected in the future. But I also will tell this gentleman that there's really, if we were to find a inherited thrombophilia, that would probably not change my recommendation, which is to continue with long-term anticoagulation, given how high risk he would be for recurrence in the future.
Yeah. So this is a classic case that I call black or white case. It's one of the extremes. This is exactly the patient that has the highest risk of recurrence. He's male, he's young. We estimate the recurrence rate in this guy up to 30% in 10 years. That's actually significantly high. You can develop really bad post-thrombotic syndrome and other things. This guy needs to be on long-term anticoagulation, in my opinion. I always tell the patient that doesn't mean forever, but means as much time as the risks outweigh the benefits. In this specific case, I agree. You can choose anything. Really, in reality, I don't see, there's no information in regards to the weight. Sometimes the weight for me is one of the bigger risks. One of the factors that will make me decide one medication over the other will be a history of a gastrectomy or some sort of bariatric procedure that includes resection of portions, because that might impact the absorption of DOACs, at least in the first phases of the surgery. In reality, we don't have many studies neither. So as Jennifer was saying, hypercoagulable workup in this scenario won't have a recommendation in the length of therapy. The length of the recurrence rate is actually higher just by the unprovoked nature of it. Sometimes I do hypercoagulable workups in this patient if they request it or if they actually want to stop anticoagulation. So I use that hypercoagulable workup as a way to tell them we're not making this decision blind. Using a hypercoagulable workup for me is a way to re-stratify him in a way. Divide the hypercoagulable workup in three groups: genetic testing, prothrombin gene mutation factor V Leiden, functional assays, which be protein S, activity, and antithrombin, and I include their protein S free antigen. The other part will be the antibodies, which is lupus anticoagulant. And remember that lupus anticoagulant has to be tested by two mechanisms to be called negative or positive. You just don't do a DRVVT and that's it. You have to do a DRVVT and a secondary testing. You always have to have at least two. So your lab has to be at that capacity. Other ones would be like beta-2 glycoprotein, IgM and IgG, and the anticardiolipin IgG and IgM. So based on that, that is my hypercoagulable workup. There's lots of other things that you can do, but nothing has a good solid evidence and sometimes confuses the picture more. Testing that gets more effective are the functional assays, specifically protein C and antithrombin. You have to know what tests are you doing because sometimes can be positive in the presence of DOAC. To answer your questions, the tests that will be more affected by a presence of a DOAC in most labs will be lupus anticoagulant, protein C activity, and antithrombin. Those are the ones that you have to be specifically careful. For protein S, typically we try to do protein-free antigen, so that should not get affected as much as I can, I always do a washout period. So
Yes.
once the patient is already fully anticoagulated, the risk of everything has already passed, and you are just in this phase of maintenance, or when you actually do the dose reduction, you just one day tell the patient stop your medication for a few days, typically I say 3 to 5. Let's get you tested, go back on your dose, we'll wait for results, and we discuss. And dose reduction is actually something I really try to push as much as I can. And ISTH this year, they published some data stating that actually patients have less complications when they're in a lower dose in comparison to a higher dose, and also that the recurrence rate for clots is the same. I try to push for that, but typically we do it once we have finished the acute phase of anticoagulation, which is the first 6 months. Then you can decide to drop the dose to lower levels as a prophylactic mechanism, but some consideration has to be taken.
Absolutely.
All right, Jen, we were talking about how we want to stop the anticoagulation, and what we have from historic data is HER2 score. But this is more relevant for women with unprovoked DVT, and that's looking at post-thrombotic symptoms, D-dimer, age, and BMI. Is this something that you utilize in your practice? And also, do you utilize repeating of ultrasound or CTA chest in someone who's otherwise asymptomatic, especially to decide should you stop the anticoagulation, whether that's for provoked or unprovoked?
I tend to use the HER2 score in patients who meet the criteria you just listed out, who may have had a estrogen-related thrombosis. And in those patients who are very adamant that they want to explore every opportunity to come off of anticoagulation if possible. In general, what's more important to me, as you see on the slides in front of you, are the risk factors that may have contributed to the patient having that thrombotic event in the acute setting. Anytime I meet a patient, male or female, the first thing I tell them is we need to decide if this thrombotic event was a provoked event or an unprovoked event. Just as Nicolas was saying for the last patient, there are some cases that are black and white. But as you can see with the risk factors listed here, there are many that can fit into a gray zone, particularly when you have the presence of these minor risk factors, such as sort of brief surgeries or outpatient surgeries, hospital admissions for a very short amount of time. And then, of course, the presence of estrogen when somebody has a thrombotic event. If you have what's called a major transient risk factor, the answer is easy. If they've just had an orthopedic surgery, they've been immobile for a prolonged amount of time due to an illness or hospitalization, then you can say, okay, you've completed your treatment within that 3 to 6 month period and you don't have to continue on. If they have these, either one or some of these, a combination of these minor risk factors, then it really does become more of a discussion where you can utilize some of these other tools like the risk score, for example. In some cases, I do utilize D-dimers to give the patient a sense of what their current risk would be. And then once they come off of anticoagulation, sort of give them some counseling about what their risk may be now that they're not fully anticoagulated. I have not routinely used CTA at all. I feel like for the benefit that you get, it's a fairly high dose. We are lucky to work in a center where we have a cardiologist who's got a very specific interest in pulmonary hypertension. He has access to very specialized testing to look for evidence of CTEPH, which might change the patient's management in the future. But in terms of just making a decision about continued anticoagulation, CTA is not something I have used. Lower extremity Dopplers, only in very rare situations. I'd be interested to hear what Nicolas has to say.
Yeah. So for this, basically, one thing I want to add, part of my workup when you get an acute clot and has a PE is actually to include an echocardiogram. We try to do that here every single patient. We want to evaluate if the size and functionality of the right ventricle. We do that in almost every single patient. For me, basically, this is when the patient comes to me for the first time, we try to see them within 3 months from the event. Typically, it's at 3 months because management won't change, basically. And I actually want to evaluate if they are back to their functional capacity. I always ask them, where are you at if I compare you to before the clot? And they will tell you 50%, 80%, 100%. I want to listen 100% or 90% or 80%. But if I don't get that, I start thinking that might be a chronic complication from the PE on the lungs. That is where imaging, in my opinion, has a role. Typically, we repeat the old echocardiogram to make sure there's resolution of the initial findings. As Jennifer was saying, we have a person that specializes in this. We send the patients, and typically what he does repeats the ultrasound, does some sort of physical assessment, assesses the functional capacity, and then orders VQ scans and uses the VQ scans to see resolution of the event. And based on that, they decide if we're going to pursue or not. Actually, when we see complex cases that complicate and they have long-term lung complications, you have to go as deep as that for the workup because it changes management. And in those cases, for example, I wouldn't even consider dose reduction. And what to make sure that the clot has resolved, I always tell patients, clots are like dinosaurs. They die and they disappear from face of earth, or they become fossils. So sometimes doing an ultrasound, you will find a fossil, basically, right? You will find this piece of dead clot. It's not going to come back to life. The only reason why I would consider doing that is when they start developing symptoms. Let's say swelling, asymmetric swelling, pain, skin changes, and we do an ultrasound just to make sure that they're not going further the pathway of a post-thrombotic syndrome that could be terrible. So yeah, for making the final decision, I would do not do ultrasound of the legs. It won't change management for me. But specifically for lung, yes, I actually make sure that there is some sort of resolution of the burden of the clot, but we don't do CTAs at first. We typically go first with ultrasounds to make sure there's resolution of changes. If they are, we'll be doing VQ scans and then pursuing the route of right heart cath if needed.
I'm going to start using that dinosaur analogy in my clinical practice. Okay, before moving on to another case, to reiterate what we've covered so far, long-term treatment for unprovoked DVT and PE with selectively decreasing the dose and considering hypercoagulable workup, whereas for provoked DVT, 3 to 6 months of anticoagulation is adequate. But now in our next patient, which again ends up being a rather common scenario in our practice, you have a young lady with newly diagnosed stage 3 breast cancer who's about to start neoadjuvant chemotherapy. But she has been short of breath. As part of her initial workup for staging as well, she's noted to have PE on her CT chest, and she was started on Lovenox. But before her discharge, she was switched to DOAC Gen in a patient like this. She's likely to get surgery in 4 to 6 months after finishing the course of neoadjuvant chemotherapy. What are the guidelines in terms of anticoagulation? Given treatment, surgery is going to be with curative intent. After her surgery, can we stop anticoagulation? What would the bridging look like? Can you walk us through this common scenario that we run into?
Sure. The way I approach patients with cancer-associated venous thrombotic events is to consider the malignancy as being the primary driving force for their underlying hypercoagulability. I tell patients that as long as you have the cancer or are being treated for cancer, you will need to be on anticoagulation, with the exception of a brief hold for surgery. I personally treat a patient with anticoagulation through their treatment, and 3 months post-treatment. At that point, they usually have their repeat scans and can be deemed cancer-free. That is usually the way I approach it in patients who are being treated with curative intent. In patients with metastatic disease who we're treating palliatively, we will always suspect that they have some degree of malignancy present or will need some sort of treatment. I will continue their treatment long-term as long as the risks don't outweigh the benefits.
And Nick, with regards to if the person was to go for surgery within that time frame where you just started the anticoagulation, within that 3-month period, what's the plan of management? Bridging or wait for the surgery after they've completed the course, which would be an ideal course, but sometimes we can't.
This happens all the time, actually. It's very common. So at least in a cancer center, how I have organized this in my mind is basically this. In the first month of therapy, I don't discontinue. I only discontinue for emergencies. Okay. And in the case that there is an emergency, there's where your possible IVC filter fits in the picture, right? So if you have a patient with a DVT and it's going to need to be discontinued and the DVT has characteristics like being proximal and other things, I would definitely consider an IVC filter in the first month if I'm going to stop it. Past the first months of therapy, I try to not discontinue anticoagulation for the first 3 months of full therapy. For the first month, I won't stop it. And if I have to stop it, I will use a secondary measure like an IVC filter. In the second and third month after therapy, I can consider discontinuation if it's a really life-threatening situation or in a situation it wouldn't have changed management. Once more than 3 months have passed from the treatment for the first event, I don't have any problem stopping for brief periods of time, doing the surgery and going back as soon as possible. But in this case, you're saying that you most likely will do the surgery 4 months after or something. And then after 3 months have passed, I stop the anticoagulation, get your surgery done, and go back on the anticoagulation as soon as possible. I always say, if we're going to do more than 5 or 6 days of stopping anticoagulation, what I will do is start you as soon as possible on enoxaparin prophylaxis and put you on some sort of more reversible agent. Because remember that these things that you have here listed work well, but you don't have a good reliability on the reversal. You only have that for warfarin, really.
Right.
So,
all right. So before we close for the next 2 to 3 minutes, can we go through a few rapid fire scenarios and give us some guidance on this? Jen, I'll start with you. Superficial vein thrombosis. When do you consider treatment and for how long?
Symptoms.
So, symptoms, exactly. That's what I was going to say. The first thing I ask is the patient symptomatic? If it's if there are mild symptoms, if the documented thrombosis is small and not proximal to a deep vein, much like showing here in your chart, then often you can use NSAIDs and warm compresses. But if they're very symptomatic, or if it meets any of these criteria shown here, I will do the 45 days of prophylactic dose anticoagulation.
And Nico, with regards to the treatment for acute versus chronic portal venous thrombosis, this is not an uncommon scenario, especially when we are tied up with patients with hepatocellular or pancreatic cancer.
Which is one. So for portal vein thrombosis, this is a tricky one, right? Because the lack of unified guidelines, depending on the society that you look into. For portal vein thrombosis in general, if you have a provoking cause for it, like a cancer or a cirrhosis, you can make a case that is provoked, but this is like one that I will call unusual location, right? So clots of unusual location need, in my opinion, hypercoagulable workups if you don't find any provoking factor. This is a classic one, the CVST that you have listed in the second one, and portal vein thrombosis of unknown cause. Those for me, and the lack of cirrhosis specifically for me are unprovoked and need a hypercoagulable workup. And these are the cases in which my hypercoagulable workup extends into the JAK2 and the PNH one. And we also order those because we have seen atypical thrombosis develop in those scenarios. Okay, so what with this one? So for these clots, you always have to give the best chance of recanalization. That's the goal of therapy here. For acute portal vein thrombosis, basically, you have to, I typically anticoagulate for 3 to 6 months. And I actually, in this case, is monitor because I want to give them the best chance of recanalization. What happens with this portal vein thrombosis, if they don't heal well, they develop bad occlusion. So they develop these cavernous transformations that apparently make life harder for transplants and things in the future. So what I would do in these cases is I anticoagulate acute portal vein thrombosis for 6 months of therapy. For chronic ones, that's a little bit tricky. In my personal opinion, I actually give them some sort of anticoagulation just to see how much of recanalization they achieve. If the clot is unprovoked or has a hypercondition, anticoagulation is forever for me. But if the clot is chronic, let's say in the setting of cirrhosis, I consider discontinuation of therapy past 3 to 6 months of therapy. In the setting of cancer, for me, the rule is active cancer on active treatment, you need to treat the clots. I always tell patients, cancer gives you clots. Cancer plus chemotherapy gives you more clots. Cancer plus chemo plus radiation gives you even more clots. And if you add a surgery, that gives you even more clots. So it's just adding risk factors on top. So those guys go on anticoagulation for long term. You can decide dose reduction based on recent data published in ASCO. That's how I would approach this case.
Just really quickly, I just want to add for portal vein thrombosis in the setting of cirrhosis, important to work with your hepatologist or GI colleagues to ensure they've been screened for varices to assist in risk-benefit decisions.
Absolutely. And then to close off, Jen, APLS, is Coumadin your only option, or can we safely use DOACs here?
So I tend to aim my practice based on results of the TRAPS trial, which showed that patients who were triple positive did not fare as well when treated with DOACs versus warfarin. If someone has one positive antibody, not a high risk thrombosis, I will consider a DOAC in those patients. If they have more than one antibody, that's when I start getting nervous. While there's not clear data on 2 positive antibodies, I tend to lean more towards warfarin in those patients, just out of an overabundance of caution.
Well, we've covered a lot here, but I'll close here where we started. Recommendations on what type of anticoagulation and duration truly depends on underlying causes of VTE. Patient preference and shared decision-making is, again, very important. Jen and Nico, thank you so much for walking us through this real-life scenarios here. For our listeners, let us go over a quick recap. In today's discussion with Dr. Jennifer Vaughn and Dr. Nicolas Gallastegui from Ohio State University, we had a chance to touch on different real-life challenging cases when it comes to VTE and pulmonary embolism. During the discussion, we touched on duration of treatment being different based on provoked versus unprovoked events. Also, ongoing data to support lower dose of anticoagulation after first 3 months in cases where risk factor persists might be a viable option.
Rohit, in our last few minutes of rapid fire question, we also touched on common scenarios such as superficial vein thrombosis, portal vein thrombosis, and what to do for APLS. This has been an exciting conversation. Thanks for joining us. Make sure to tune in into our other discussions around challenging cases, tox check discussions, and treatment algorithm episodes. We are the Oncology Brothers.